Drinking water is our zero-calorie, non-sweetened alternative for sugar-sweetened beverages. It's healthy, it's affordable, and whether it's tap, filtered, or bottled, it's more environmentally sound. But to enable this healthy habit, for the most children, there are three things we need to pay attention to: safety, access, and promotion. The water needs to be safe, we need to provide it, and we need to encourage it. This is necessarily going to be a quick overview of a pretty broad and complex topic. So first, let's zero in on water consumption for children aged 0 to 5. Are they drinking enough water? Is their total water intake enough? And what do we know about disparities? And this is basically a quick sort of flip side review of everything we've just been hearing about. So these figures are from studies based on recent NHANES data. They show the percent of children consuming each beverage category. And I'd really like to point out three main features. Look at the percent drinking formula. It's well over 1/2 of 0 to 12 months old, and I'll get back to that in a minute in terms of water. Second, we can be glad that so many of them are drinking water, and according to Mary's presentation, it might actually be higher than what this slide says. However, we might equally say, by the time kids are aged 2 to 5, why are they not all drinking water? And finally, as the previous speakers have made clear, it's all about developing healthy habits, and we see they're developing unhealthy habits. Now, how about hydration? We don't have a lot of information on hydration status, but the evidence suggests that infants and toddlers are adequately hydrated, but by the time children are approaching school age, there's a likelihood of underhydration. Several recent studies show disparities in juice and milk consumption. I found one that looked at disparities in tap water consumption. Patel et al. Used 3 releases of NHANES data. They found that 83% of children reported drinking tap water, 10% drank bottled water, and 7% reported drinking no water. Tap water consumption was less prevalent in 1 to 2-year-olds than in school-age children. Girls, Hispanic, and Black children drank less tap water, but having a college graduate parent doubled the likelihood of drinking tap water. So you can see that these findings are consistent with the juice and SSB findings in the same age group. Water consumption and weight status. Well, we need more study on this in this age group. As Steve pointed out, there are some promising studies in older children and adults, and I list a few of those findings here. Jody Stuckey just published an interesting review looking in greater depth at some of the same kinds of factors Steve was talking about: pre-intervention weight status and other components of diet and how they bear on the success of these interventions. So in sum, we need a better evidence base, but the evidence suggests that if we put aside, sorry, I turned my slide a little quickly, but this one is probably more enjoyable to look at. If we put aside the sort of breastfeeding versus formula issue, children start life with a healthy beverage intake profile, but it doesn't take long before that profile is less healthy and before perhaps they don't have enough intake of beverage in general. And these unhealthy trends are seen disproportionately in certain groups, notably Black, Hispanic, and low income. Okay, so we want to make plain water the normative beverage after age-appropriate amounts of milk in this age group, and we want children to be able to make that water tap water most of the time, and that's because it's a disparity reducer. It's economical, it contributes to clean environments, adequate hydration improves children's school performance, and when it's fluoridated, it boosts oral health. Tina and Judy both brought out the safety issue, and I'm going to spend a little bit of time on that because it's really the first step as we think about providing water. So lead in water has had a lot of attention recently, and children under age 7 are the most vulnerable to the toxic effects of lead because of their increased gastrointestinal absorption of lead, as well as because their brains are more vulnerable to the neurotoxins in lead. Now, I mentioned formula. Lead is especially a concern for formula-fed infants, and here's why. As Anna Marie's work showed, the majority of infants consume formula. In fact, 60% of infants 0 to 5 months are entirely formula fed. Infants consume up to about 4 cups a day. That's typically mixed with tap water. So it makes that the most water of all age groups, most water intake of all age groups in proportion to body weight. CDC says that tap water may account for 60% of total lead exposure in formula-fed children. So we normally think about soil, dust, and other sources of lead exposure, but when we're looking at formula-fed infants, we need to think about water. And finally, socioeconomic and other factors associated with formula feeding may also be associated with marginalized regions more likely to have unsafe tap water. An analysis by Mark Edwards demonstrated that the relative risk of exposure to high lead in water was a strong function of zip code, which, as we know, is a health indicator in general. So how do we get contaminated water anyway? There's kind of 2 categories. There's source water with contaminants such as nitrates or arsenic. And when the utility doesn't treat the water correctly, this can then result in utility water that's provided that's contaminated. The CDC Environmental Tracking Program suggests that 5% of community water systems supply unsafe drinking water in any year. And of course, private wells can also yield contaminated water. The second source of category of water contamination is lead, and lead enters the water after it leaves utility mains. So here's my illustration. It enters service lines and then premise plumbing. And lead can leach or flake into water from lead service lines or from lead parts in premise plumbing. So look at this map. These are contamination incidents of tap water all around the country. We got this information through reports in the media. The red and green dots represent lead contamination in school and in community water. The blue and purple dots represent other contaminants in school and community water. The number of dots on the map suggests that existing regulations, guidelines, and systems do not always safeguard our water. Does safe tap water relate to childhood obesity? If you look at this map of California tap water safety violations next to mapping of childhood obesity, it's easy to see that there's a lot of overlap. We don't have the evidence to find causation, just correlation. But the same kids without safe tap water are often those who are drinking too much SSB, have some of the highest rates of childhood obesity, and of dental caries. And later in the workshop, you'll be hearing from our colleague Henrietta Sandoval about these issues on Navajo Nation. Trying to find out whether kids are exposed to lead or other contaminants in tap water is literally all over the map. As you can see, 14 states plus DC are now testing for lead in school tap water. An update on this map: just a couple days ago, the legislation in Texas failed. It's notable that nearly every state colored in on this map has a different approach to ascertain the level of lead exposure in school tap water, and I'm happy to tell you more about this at another time. What has testing for lead revealed so far? We've collected preliminary data from data made public by these states. I won't go over the details, but just say that there's quite a range in lead exposure, from less than 1% of taps with an elevated lead level found so far in California. So far, only 8% of our schools have been tested so far. To Massachusetts, where 60% of schools had at least one tap with an elevated lead level upon sampling. New York State is the only state that has almost completed sampling in its schools, and they're finding about 12% of taps have a level elevated over the EPA action level of 15, which is the level that most states are using as their action level. Okay, how about childcare? As I explained, it's really younger children that we need to worry about in terms of exposure to lead, and a handful of states have some provision for testing for lead in childcare water. Massachusetts and New York City are perhaps the most successful so far. In New York, results show that about 8% of taps are above the current EPA level of 15 parts per billion. Rhode Island is offering voluntary childcare testing, but there's little uptake so far. I talked to someone in Rhode Island running that project who said that it's the fear of the costs of what they're going to do if they find that there is a problem. Illinois is the only state to require testing in all licensed childcare, but their legislation requires that they develop a protocol for the testing by next January, so they haven't started yet. New York State includes certification of testing as a requirement for childcare licensing, but to be effective, this needs to be monitored. And in Washington, childcare is included in legislation for mandatory testing, but the program is conditional on funding, and that hasn't been appropriated yet. So basically, these illustrate the variety of barriers to tap water testing in childcare. What are some other actions for safety? I'm sure you all know that AAP suggests that we ensure that all water fountains in schools do not exceed water lead concentrations of 1 part per billion. USDA provided a memo to National School Lunch Program and Child and Adult Care Food Program operators on safety and available resources. And this is important because the majority of schools are on NSLP, and CACFP is half of all licensed childcare. On the federal level, many bills have been offered related to testing. Last year, 39 bills, and infrastructure. This year, there's a handful underway, and I'm happy to provide more information on those. So to recap, most of us do have safe water, but not all, and especially not in certain areas, which include areas subject to agricultural runoff, industrial pollution, mining or fracking activities, and rural and inner city areas. There's too much that we don't know and we lack consensus on. We need better surveillance. We need to analyze those data coming out of states so that we can target risk areas better. But given that most water is safe, we need to find and fix the problems, and as Steve is fond of saying, we know how to do that in this country. So let's talk about access and consumption. The slide shows a childcare meal with milk and water on the table in child-sized pitchers. Studies in school settings show that improving access to water and providing education about beverage choice is associated with increased water uptake. 2 examples here. Muckelbauer's seminal work, Increased Access with Fountains and Water Bottles, included teacher-led education. The intervention increased children's water intake by almost 1 cup per day and was associated with a significant decrease in the risk of overweight. Kenny et al. Improved access through providing cups and promoted water with posters. More kids drank water, they drank more water, and fewer drank sugary beverages. UCSF and NPI are partnering in a study now to replicate and expand on Muckelbauer's work, and will also be investigating the intervention impact on food and beverage intakes. The only study that I'm aware of in childcare is this small unpublished pilot by Anisha Patel. The intervention consisted of environment change, which was water testing and remediation, reusable water bottles for childcare and home, and pitchers and cups for childcare, combined with education on drinking water for parents and development of beverage policy for the centers and homes. There was a trend for impact on BMI, but the p-values were insignificant because the study size was so small. However, Anisha told me yesterday that they're planning to submit a proposal for a larger RCT. The intervention affected beverage practices at home. The slide shows the changes: more water, less whole and 2% milk, more 1% and skim, less juice, and no change in overall milk intake. So policy on water can be a key lever for access, and we already have important water policy in the federal child nutrition programs. I show the child and adult care food program drinking water provisions here. New guidance requires that providers not only make water available, but that they also offer it, preferably with visual cues. That will be in effect on October 1st. USDA recognizes that small children may not notice they're thirsty and may not be able to ask for water. CACFP, as I mentioned, is half of all licensed childcare, but in addition, about half of all states tie their nutrition standards for all licensed childcare to these CACFP standards. Here's an overview of the CACFP beverage standards in general, and as you can see, they align pretty well to recent HER and AAP recommendations. But as with any policy, it needs to be implemented effectively. Simply having access is not enough. Research shows the importance of promotion and education in schools, and there are a number of promotional materials for the child care setting out there. I'm not sure that any of these have been, a lot of them are developed with focus group work, but I'm not sure about the actual evidence base or evaluation of the use of these materials. We developed a two-pager that outlines CACFP requirements, water requirements, and shows some of the best practices I've been talking about. Ensuring and assuring parents that water is safe, providing easy access throughout the day, making sure to offer water, and promoting water. So I'd like to wrap up with some facilitators, barriers, and opportunities for this strategy. We do have some powerful facilitators. Water is a positive message. Parents, and not only parents, but grandparents, child care providers, and even policymakers care about children's health and oral health, and water supports both. I haven't mentioned much about oral health, but oral health is very important to people. It's a major chronic health problem, and the oral health world considers that the switch from sugary beverages to water is a very important strategy. So they're huge partners in this work. And finally, the CACFP standards are a big step ahead for water in childcare through a major federal nutrition program. Oops. I must cover barriers too. We do have some barriers. Sometimes tap water is not safe, and when it's not, the cost to buy or filter water could make SSBs look like a good choice. Legislation for additional food assistance benefits for those who need to buy bottled water is pending in California, and I'd like to see similar additional funding for CACFP and Head Start sites who lack potable water. On the other hand, misperceptions about safety are probably a bigger barrier than actual safety. And these can also be an unintended consequence of all the talk about testing programs and safety issues. Gallup polling in April showed that 63% of Americans worry a great deal about water pollution. Evidence gaps are another barrier, and a short list includes safety, for example, perceptions and the magnitude of the safety problem. We could use a definitive study of the impact of water intake on milk and food intake. This is another feared unintended consequence of water promotion. My boss, Lorene Ritchie, found water consumption with meals does not displace other healthy beverages and foods in childcare, but we need a bigger study on that. A few other questions. Can promoting water reduce SSB intake, or does it need to substitute for SSB? I think the latter. Will restricting access to SSB actually drive increased water intake? And we need to track any uptick in consumption of artificially sweetened beverage in this age group. That would be another unintended consequence. And I see I still have 5 minutes. So the last barrier is what I call mixed messages. It's kind of a case of do as I say and not as I do. Modeling matters, and many parents and caregivers drink SSB. The other mixed message is I think that parents and caregivers need simple, clear information on healthy beverage practices. We recently held a workshop on interventions to increase water consumption in 0 to 5-year-olds, and the Access Work Group was in agreement that kids generally, they're at home, they're in childcare, there is access to water there. We assume it's safe or we need to make it safe, but what we really need is clear knowledge for the parents and caregivers on what children should be drinking, how much, how they should ingest it, when can you introduce the sippy cup with water, et cetera. And further, they identified, as I mentioned earlier, that oral health care providers can be a key messenger to parents. So finally, a few big opportunities going forward. In the safety arena, let's add licensed childcare to school testing initiatives. We're pushing for this in our California testing initiative. Access. Implement the offer requirement in CACFP and extend those CACFP requirements to more settings. Education. Strong language about water in the 2020 dietary guidelines, and how about a symbol for water on the MyPlate graphic? This is a very popular idea with audiences around the country. It would support healthy beverage counseling in WIC and nutrition education through SNAP-Ed and other programs. And I have to say that numerous childcare providers have told me, the kids ask me, why isn't water on my plate? Okay, I'd like to acknowledge the contribution of partners in the National Drinking Water Alliance to my presentation, and thank you for the attention to water today.